Welcome everyone to today's webinar. We're going to give a couple of minutes for people to join in and we'll get started shortly. Thanks very much. Right, well, it looks like a few more people have joined, so we'll get started. Um, yeah, welcome everyone to today's webinar. My name is Sean Lassiter. I'm the Assistant Director of Learning and Development at IHME. And I'm helping to facilitate this session today. And we'd just like to extend a very warm welcome to each of you. Thank you for joining us for this session on sex differences in health, insights and exploration of results from GBD 2023. This session will do a couple of things. First, we want to discuss the patterns of health outcomes between sexes, drawing on the latest findings from GBD 2023. In addition, this session will also highlight emerging trends, gaps, and implications for public health policy, research, and gender-sensitive healthcare strategies. And there'll also be a tutorial on using GBD Compare sex differences tool to explore GBD estimates related to sex differences. Very pleased today to be joined by Dr. Luisa Flor, who will be today's presenter. Um, Dr. Flor is an assistant professor at IHME and the Department of Health Metric Sciences at the University of Washington. She co-leads the Gender Equity or Gender Equality Metrics team, which is dedicated to investigating the various social barriers impending gender uh, equality and health and developing a robust metric for measuring the impact of gender-based violence on health outcomes. In addition to this work, she also works on the GBD study, where she leads the effort to estimate the disease burden attributable to tobacco-related risk factors and to assess the impact of tobacco control measures globally. Um, her her work on uh, So Dr. Flor is originally from Brazil, and she's earned both her master's and doctoral degrees in public health from the National School of Public Health in Brazil. Following her doctoral work, Dr. Flor undertook a postdoctoral fellowship at IHME, where she primarily worked on the GBD study. During this time, she developed innovative methodologies for analyzing complex behavioral risk factor data and evaluating the impact of policies and programs aimed at combating non-communicable diseases in low and middle income countries. Dr. Flor is also passionate about teaching and mentoring students, research fellows, and local stakeholders uh, on measuring what matters. Um, Before we dive in, we'll just briefly discuss our agenda and some housekeeping, and then I'll hand over the floor to Dr. Flor. So today's session will spend approximately 35 minutes looking at the results from this study and also the GBD Compare sex differences tool, followed by a 15-minute question and answer segment. Um, so during the session, you can submit questions to the using the Q&A feature in Zoom, and then we'll answer those during the dedicated Q&A segment, but do feel free to engage in the Q&A chat throughout the session. Just also wanting to let everyone know that this session is being recorded, and the recording of this session will be made available on our website following the conclusion of the webinar. And I will post a link to where you can find that webinar on our website. Um, and then just out of necessity, mics and cameras are muted. So if you'd like to have a question, we just again use the Q&A feature. With that, I'll hand it over to you, Dr. Flor, for the presentation. Thanks so much.
Thank you so much, Sean, for the introduction. I'm very happy to be here today. So we're going to be talking a little bit about GBD 2023 results pertaining to sex differences in health, but I'll also use this opportunity to talk a little bit more about the scope of the work of our gender equality team. So let me start by giving you a more detailed outline of what we are going to cover today. First, I'll give a short introduction to IHME and the Global Burden of Disease, or the GBD study. If you have joined any of our other learning sessions before, this may sound a little bit familiar or even a little bit repetitive, but I promise to keep it brief. Next, as I mentioned, I will introduce the gender equality team and share some of the key results from our recent work on sex, gender, and health. And after that, we are going to look at our new visualization tool, and I will do a live demonstration of how you can use it to explore sex differences in health using the GBD outputs. And finally, we are going to finish with some key takeaways and the Q&A time by the end. So to start, the Institute for Health Metrics and Evaluation, or IHME, is an independent research organization based at the University of Washington School of Medicine in Seattle, in Washington State, in the United States. And as many of you might know this already, IHME works on many global health research projects, but I would say that the Global Burden of Disease, or the GBD, is our main or flagship project. So what exactly is the GBD? I like to think of GBD as a rules-based evidence synthesis for global health. And it is a scientific effort to measure health loss, looking at diseases, injuries, and many risk factors. And the first GBD study was actually conducted in 1991, covering around like 100 conditions, only 10 risk factors, 5 age groups, and 8 world regions. And today, actually, like last month, we just launched the newest or the most recent cycle of the GBD, which is the GBD 2023, where we have data or estimates from 1990 to 2023 covering over 300 diseases and injuries and over 80 risk factors. So such like a big expansion since our first study. And also we produce those estimates for over 200 countries and territories. If you're interested in learning more about the history of the GBD, our director, Professor Chris Murray, wrote this great paper a couple of years ago for the GBD 30th anniversary, which is published in Nature Medicine. So the main idea behind the GBD is that everyone deserves to live a long, healthy life, and GBD tries to measure that, or measure what stops us actually from reaching this goal by counting healthy loss due to diseases, injuries, and risk factors. And by health loss, we are interested in understanding that health loss both due to premature mortality, but also due to years lived with disability. And this framework and this effort helps us see how big different health problems are and whether things are getting better or worse over time, and how different countries or different populations are feeling the burden of different conditions, injuries, and risk factors. So as I mentioned, the latest GBD cycle was GBD 2023 was released last month. And the main papers, which we call capstones, were published in The Lancet. This set of publications gives us updated estimates of health loss around the world up to the year 2023, and you can find all of these papers online. So I know that like many of you are GBD collaborators or have or are involved with the GBD in some sort of way. And you might know that the GBD 2023 scope is very large. So it covers specifically 375 diseases and injuries, including conditions that affect only men or only women. It includes over 3,500 sequela, 9 impairments, and 88 risk factors. And we produce estimates actually for 925 locations, which includes 204 countries and territories, but also subnational units in 20 countries, including Brazil, Mexico, Indonesia, Norway, and Ethiopia. This study covers 25 age groups, 33 years, and our results are always broken down and shown, made available by sex. So for males, females, and both sexes combined. As part of the GBD, we produce many indicators each cycle, and this includes the number of deaths or deaths by cause, and how common diseases or injuries are by estimating prevalence and incidence of diseases, for example. And we also summarize health loss using a measure called disability adjusted life years or DALYs, which represents or summarizes the health loss due to both years of life lost and years lived with disability. We also look on the risk factor side, how much of the health loss or how much of the burden is attributable or caused by each of the 88 risk factors. We won't spend too much time today going into more detail in each of these indicators, but we do have a separate session or a separate learning session on interpreting GBD measures and metrics. You can find more information about that session on our website, which also has a link to a YouTube video that you can watch if you cannot attend any of the remaining time slots. And maybe at some point, Sean can also share the link in the chat for this page. So again, like I know that like many of you are GBD collaborators already, but I always like to highlight that a key part of the GBD is our large collaborator network. In the past 16 or 17 years, we have worked with more than 17,000 collaborators from 167 countries. As you can see on this map, we have people working with us and helping us improve the GBD from like almost like every country. And collaborators help by finding important data, checking our models, reviewing estimates, helping us write papers and policy reports, and many other tasks. And I imagine that like many of you have been engaged in some of these tasks already. So I just want to extend my gratitude for all the work in like helping us like improve the quality and impact of the GBD. Now I would like to focus on our gender metrics team a little bit. This is our GEM team and how this team contributes to the GBD, but also how we use some of the GBD outputs and estimates to create additional research, especially covering aspects related to sex, gender, and health. But before we dig into like the GEM team work, it's important to discuss how sex and gender influence health outcomes and life trajectories. When we here at IHME refer to sex, we are talking about biological aspects related to being female or male, such as anatomy, physiology, genetics, and hormones. While when we refer to gender, we are talking about social and cultural aspects related to being a woman or a man in a specific society. And this includes things like identity, roles and norms, relations, and power relations as well. We understand that like both sex and gender can interact, and both of them affect health and create differences and help us explain differences in health that we observe between males and females. And when we talk about these factors or how these factors affect health, we usually think about like three things. So we need to like be aware that first, there are health conditions that are specific to one sex due to biological aspects and how females and male bodies are composed. And this includes things such as like cervical cancer or prostate cancer. Second, there are health problems that impact one sex more than the other, even if both can be affected. And this is like a combination of factors. There might be some like biological factors, but we understand that like most of those differences might actually be explained by gender related aspects. And third, there is no way for us to talk about GBD estimates or health metrics without thinking about data and also like the health data bias that exists related to sex and gender. For example, we can think about like research that's mostly done on one sex or when data misses important sex differences. And these three aspects are the core of the work done by the gender equilimetrics team here at IHME. So the GEM team was established in 2020 through the funding from the Gates Foundation. And the main goal of the team is to integrate a gender lens into all projects across IHME. And the main goal here is to strengthen the evidence-based linking gender and health. And I mentioned this already, but the GEM team helps estimate some GBD results, but it also does detailed analysis using GBD estimates. And with this new team, this new dedicated team at IHME, we moved from just showing results or making results available by sex to looking more deeply at both sex and gender differences with a special focus on women's health. So a lot of the times in the next slides, you're going to be hearing me talk about sex, gender, but you're going to feel that there is like a heavy focus on women's health. And this is a core part of our team's work. And here in this slide, I have also selected three of our main work areas in the past 2 years. These are not comprehensive at all, but I selected the three that I wanted to cover today. So the first one, and Sean mentioned this already, but we are responsible for improving how we estimate the burden of gender-based violence and violence against children as part of the GBD. And using the GBD estimates, we have been conducting analysis and evaluating health disparities, and we have actually completed a first study on health disparities in female-specific conditions. And the third area of work is looking at data gaps and sex differences in health, also using GBD data. I'll explain each of these areas very briefly in the next slides, but we will spend a little bit more time on the last point here. So let's start with our work on estimating the disease burden attributable to violence against women and children. So if you're familiar with the GBD, you know that we currently include two risk factors that represent violence against women and children. The first one is intimate partner violence, or IPV, defined as physical or sexual violence against women by a current or former partner since the age of 15. The second one is childhood sexual abuse, measured as unwanted sexual contact or intercourse under the age of 18. And for GBD 2023 specifically, we improved how we estimate the prevalence of these risks and also reassessed how they are linked to health outcomes. I have included like a couple of like screenshots of publications from our team in this slide. And these publications, they describe some of these new methods and findings in a little bit more detail. So let's go into like what exactly we did. When I say that we improved these estimates, what exactly we did for GBD 2023 related to those two risk factors. So more specifically, we have completed a huge systematic review of the literature published between 1970 and 2024 that allowed us to expand the number of health outcomes we link to both IPV and childhood sexual abuse in the GBD. For example, now in GBD 2023, we have 8 outcomes associated with IPV compared to only 3 that were available in GBD 2021. And we now have 14 outcomes, health outcomes, linked to childhood sexual abuse compared to only 2 that we had in GBD 2021. Additionally, for the first time, we also corrected our estimates of childhood sexual abuse for underreporting, which actually increased our prevalence estimates. And as we do every cycle for all GBD causes and risks, we also added new source of data for both risks. And all of these changes have had a big impact of the burden estimates for these risks in GBD 2023. And this was like briefly described in our risk factor capstone published last month in the Lancet. But more details will be available in a new Lancet publication that will actually come out next week. So here's just like one big spoiler. So one of the most important findings is that those 2 risks now rank among the top drivers of health burden globally, especially among young people. So for women, for IPV and childhood sexual abuse, they are now in the top 5 health risks globally, even higher than like other well-known risks like high blood sugar, high blood pressure, or smoking. For males of that specific age group, sexual violence against children now ranks number 11th. I won't share too many other spoilers today, but stay tuned for the publication that will come out next week. Now let's move on to the second area of work that we are going to be covering today, and this is on health disparities in female-specific conditions. So this area of work actually helps us see where progress is being made and where there is still room for improvement. So in this analysis, which was also done with data from GBD 2023, we looked at 5 female-specific conditions: maternal disorders, female breast cancer, and we know that breast cancer is not a female-specific condition, but let's say it's like a female-dominant condition, uterine cancer, ovarian cancer, and cervical cancer. And again, this was using GBD 2023 data. And we developed like this stochastic frontier analysis where we estimated the lowest achievable burden for each of these conditions across different levels of socioeconomic development. And by comparing the actual burden observed in each country to this minimum achievable level, we calculate what we call like an achievement gap or a performance gap. And this gap shows where opportunities for improvement have actually been missed by countries. And you can find a detailed description of our methods and our results in one of our publications that came out in like a couple months ago in the Lancet Women's Health Journal. And here is just like a very high level of like some key insights and key results from that work. We found, importantly, that opportunities for progress exist in every region and at every level of development for all the conditions that we assessed. Even high-income countries can further improve their health systems, especially for female cancers. On this slide here, you can see the results that I selected for 2 conditions specifically. The top plot shows the gap between the observed and the minimum deaths for breast cancer across different levels of development, while the bottom plot shows this for maternal disorders. Each point on these plots represent like a country, and they are colored by GBD superregion. We can see here that for maternal disorders, the biggest opportunities for progress are in sub-Saharan Africa. So this represents the number of DALIs that they are further away from the minimal achievable or the frontier burden for this condition. For breast cancer, on the other hand, the gaps are more spread out across the levels of development. And like, let's go to the high income, which is those which are represented by the pink color here. And this data point here is Monaco. So a high income country that we can see that performs far worse than their peers in the same SDI level and GBD superregion. Importantly, countries with higher burdens have peers at similar development levels who are doing much better. And this is like true for all conditions and across all super regions. We can see, for example, here, like Palau, for breast cancer, it's doing like, it's performing worse than their peers in the same region or the same development level as well. This suggests that sharing best practices and policies across countries or across their peers could actually help countries, many countries improve their burden for like female-specific conditions. One thing that was also very interesting is that we compare the performance of countries for overall burden among females to their performance for female-specific conditions. And we also found that some countries like Japan, Nepal, or Vietnam that do well on overall female disease burden, they still actually have inefficiencies in the specific female dominant areas. And that means that their health systems are good at handling, or they're not as inefficient in handling general female health. That includes like conditions that also impacts like females and males, but may need more focus on female conditions, especially like on female cancers. So let's move on to the last major area of work that we are covering today, which is assessing the sex differences in health using GBD data. So this work helps us understand where females and males experience different health challenges and why this difference matters for policy and research. So I know that we are here today to talk about like key insights from GBD 2023, but actually this work started with GBD 2021 results. So we began by describing GBD 2021 results through a sex and gender lens, and key insights from this analysis were published last year in the Lancet Public Health. In that study, we quantified the differences between females and males for the top 20 causes of burden, both globally and by superregion, across age groups and from 1990 to 2021. So this here is like one plot it's included in that publication and shows the results at the global level. Here on the y-axis, you see the 20 causes of burden we analyzed, and on the x-axis, it's the absolute difference in daily rates between females and males in 2021, calculated as the rates among females minus the rates among males. We found that for most causes, men were disproportionately affected, and you can see that those are represented by all the causes where the bars are colored in blue. This is specifically true for COVID-19, ischemic heart disease, and road injuries, where we see that the gap disfavoring males compared to females is are like on the top. Females, on the other hand, were disproportionately affected by low back pain and other musculoskeletal disorders, mental health conditions such as depressive disorders and anxiety disorders, also headache disorders and HIV at the global level. And overall, the absolute gaps, we can easily see this from this plot, the absolute gaps were actually smaller for conditions disproportionately affecting females compared to the gap disfavoring males. So this is one of the key takeaways from that study. One interesting thing is that most of these patterns are consistent across world regions. So the direction of the difference is basically the same across regions. The only exception we found for this top 20 conditions was HIV. So we can see here on the plot that globally, women have larger burden due to IHV. But in regions outside sub-Saharan Africa, that's not true. So outside of sub-Saharan Africa, men actually bear a greater burden. But I didn't want to leave you without GBD 2023 results. So just in preparation for this meeting, we actually recreated this analysis using like the latest results. And actually as we expect, the patterns still hold. There's like not much variation between like the last cycle and this cycle. The main change here is in the selection of the causes, of the top 20 causes of burden globally. For example, here, COVID-19 is no longer among the top 20 causes of burden in 2023, leaving ischemic heart disease as the leading gap disfavoring males. So when we think about that publication and we think about that area of work developed by the gender equality team, another super interesting key finding is in the nature of the conditions that disproportionately affect females and males. So we found that conditions affecting or disproportionately affecting females, they are mainly leading to healthy life loss due to years lived with disability. So the major component of those conditions are YLDs, meaning that they result in loss of healthy life due to morbidity and disability. Whereas conditions affecting males or disproportionately affecting males are mostly linked to premature mortality, leading to shorter lifespans among males. We also found that for conditions impacting females, differences start early in life and actually increase with age. And that's partially true for males. So one of the major causes of burden disproportionately affecting males is road injuries, where actually the burden starts like very large because the major gap between males and females is among young individuals, and that gap actually like decreases over time. And another interesting finding was that although the overall burden for most of these conditions have largely decreased over time for both sexes, the gap or the difference between males and females has remained mostly stable over time. So we are making progress for both sexes, but we are not reducing the observed differences between males and females. So I would say that like despite being what we could call, I don't know, like a simple descriptive study using GBD estimates, our publication gained significant media attention worldwide. So we had like articles and media covering this work from like different countries. This highlighted to us the importance of these comparisons and actually inspired us to think about new ways to share these insights and support future research. And that's exactly where our new visualization tool comes in to make these insights more accessible and actionable. So we discussed this a little bit, but compared to like the GBD, every cycle of the GBD produces billions of estimates each cycle. But of course, and understandable, our published papers can only cover a fraction of what's possible, right? Like we are limited by, I don't know, 3,000 words. So for example, in our sex differences paper, we focus on global and super-regional results. So not going to country level specifics. We also included only major cause of burden that were within the top 20 causes of burden globally. So that means that we might have like left out conditions or causes that may be important in specific locations where like there will also be like a lot of like sex differences and variations. We also presented broader age groups than those available in the GBD. So we started at 10 plus and like created three age groups within that. And of course, like we didn't cover one like important aspect of the GBD. So we didn't cover the sex differences in burden attributable to risk factors, for example. So thinking about like these gaps and thinking about like these limitations, thinking about the fact that we cannot cover everything in a publication, and given all the media attention and the interest in those results, we actually developed a new visualization tool to disseminate sex differences results more broadly. So this tool is not like a one-off product, but it's actually part of a suite of interactive resources provided alongside the GBD. If you go to our website, you're going to find like a section called interactive data visuals. And there you're going to find like links to several different, visualization tools produced by the GBD. We have GBD sex compare, the GBD cancer compare. We have GBD compare. And you can find more information about like the variety of visualizations we produce in our website. And I'm happy to like share the link at some point in the chat. So if you have been interacting with the Global Burden of Disease study at some point, you probably already familiar or know that like GBD compares exist. So GBD compare is, I would say, our most popular visualization tool. And it lets users explore trends and patterns across a wide range of outputs, all disaggregated by sex for both by sex and for both sexes combined. However, one thing that we need to understand is that the GBD compare was not intended or designed for direct comparisons between females and males estimates. And I don't know, I believe that like that's one of the reasons, or that's likely why our paper insights got so much attention, because that was like the first time that we are actually intentionally like looking at GBD results with like the sex differences lens. So thinking about that and thinking about like maybe that I won't say like limitation, but that non-intention of GBD compare. So we created our GBD sex differences tool. This new tool works very similarly to GBD compare, which is great for those familiar with that other visualization. But it's focused specifically on exploring trends and patterns, not in the level of the burden, but in the differences between males and females across GBD estimates. With the new visualization tool, you can explore several dimensions of our estimates. You can, for example, compare the direction and magnitude of sex differences in diseases, injuries, and risk factors. You can analyze how these differences change over time and vary by age. You can drill down, which was something that we have not done in our publication. We can drill down to country and subnational levels for more granular comparisons. And at least for me, like one part that I find super interesting is that you can directly compare the ranking of diseases, injuries, and risk factors between males and females. If you have played with the GBD compare at some point, you know that we have ranks uh, of cause of burden there. And it usually compares a year to another. Usually we do this a lot with like 1990 versus the ranking now. But we actually created a new visualization tool that lets you compare like directly in the same view the ranking among males and the rank among females. So the sex differences tool, as other GBD visualization tools, helps us answer important health questions. And I just like selected three here to give you like an idea. So for example, we can ask, where are the largest sex differences in health outcomes in absolute and relative terms? We can ask ourselves how sex differences in HIV, for example, have changed over time. We can ask, at what ages do sex differences in mental health outcomes first appear? This is something that we are able to answer with this tool. And of course, like many more depending on your interests and needs. So now we're gonna move, we'll do like a live demo of the tool and highlight its unique features. After this training, the goal here is for you to be able to navigate many of these features independently. So here, there is like in this slide a link to the visualization tool. If you'd like, you can go ahead and visit the page so you can follow along. And the first thing that you're gonna see if you click on that link or if you go to that page is like a signing page. You're gonna need to, you can either like use your GBD Compare login if you have one, or you can create a new account. That's like very simple and fast to do to access the tool. I'll give you a couple of minutes to get set up while I also prepare my screen for the live demo. So I'll like briefly stop sharing so I can reshare my screen with the visualization tool. Okay, while you go into that link, or if whether like you want to go into that link and follow along, or you want to follow taking notes and like paying attention to the presentation, I will do like a live demo demonstrating like some key features. And I know that like many of you are familiar with GBD Compare, so I'll try to focus because we don't have like a lot of time on things that are like very specific to this tool. But we also have like a specific GBD Compare training session if you want to learn more about like more detailed aspects of the visualization, the GBD visualization tool features that are also are gonna be super useful for the sex differences tool. Um, so when you look in, the first screen that you're gonna be at is something like you can see here on my screen. And one thing that we try to do to help like uh, this to be like a smoother transition to all GBD Compare users is to keep the structure very similar to GBD Compare. So you can see here that on the left side of the screen, we have the selection panel where this is where you're going to select your estimates of interest, your population of interest, your geography of interest. So this is like basically like the same thing that you can see in GBD Compare. The other thing we can highlight is here on the top right, we have like some option panel. So in here, I think this is like very important for us to highlight for those, especially for those not familiar with GBD Compare. So this here, we have like a link where you can find more help and information about the tool. We have like something that might be very useful to some of you. We have like a language panel. So we have 17 languages that you can choose from that will make all like that will translate all the tool for you, not only the selection panels, but also all the information that shows up, for example, when you hover over a country and like a specific estimate. Another feature that's might be really useful is the share. So the share means that like if you're interested in creating a map or a figure or a visualization for a specific purpose, you can share that to your email or share that with like someone else. You can also use that option here to post that visual in your social media. One thing that I always hear from people is that, or I learned that people are doing is that they are taking screenshots of some of the visualization tool visuals. We actually have like this feature over here, which is the download, which will like, if you click here in a screenshot, for example, it will download a very high level resolution figure for you. If you want to, for example, add something to like a PowerPoint presentation or external presentations for your team or for stakeholders. The other important thing here to highlight is that you're actually able to also download the underlying data that feeds and that is used to produce each of these visualizations. So these are like some important options for you before we start like playing with the tool actually. And again, I mentioned that this is only one of the tools produced along with GBD. And if you want to see more options or more visualizations, there is also this link on the very top like right here that will like give you the opportunity to play between tools, including like moving from this tool to GBD Compare or the GBD Cancer Compare. So this is like the very high level of like the selection panels. But let's look at this let's look at this like panel here on the far left. So basically, this one thing that's different from GBD Compare is that for this tool specifically, we have four different visuals. And each of these visuals, if you can hover over here, it's going to give you the name. So we have a map, we have the arrow diagram, we have the heat map, we have the plot, and we have the line. So each of these plots here, they have different intents for users, and it displays like different uh, options based on your selection. So let's say that you're interested in seeing how things have changed over time. Maybe the map is not the best visual for that. But then we're going to have the line map, the line plot option. But we are going to go over briefly each of those to give you like a sense of like the information that's available in this new tool. Another thing that I like to highlight, and this is very similar to GBD Compare, is that here close to the settings, we have the option of like either using the basic selection panel, which is the one that's displayed over here, or you can click and use advanced settings. And the major difference between the basic and the advanced settings is how many options you have to select. For example, like while in the basic settings, we have measures, while these DALIs and DAS, because these are like the ones that people are mostly looking at. If you go to advanced settings, you actually have way more measures to select, including things such as like life expectancy, incidence, prevalence of diseases. And that's the same thing for other options here, such as ages, for example. We have way more ages for you to select using the advanced settings. So I'm gonna keep in the advanced settings for now, but let's take a look at this first plot here. I'm gonna just select like a specific cause, and I'm gonna select one that I have mentioned during my presentation, and that was a highlight of our study. So let's select HIV/AIDS, and I'm gonna select AIDS standardized because we want to compare across countries, removing the fact that countries have different age structures, compositions. And one thing that is unique to this tool here is that you can decide whether you want to see sex differences in health outcomes in absolute terms, meaning that it's just like a subtraction of the rates of males or the number of deaths, for example, among females minus the same metric among males, or if you want to see it in relative terms. So let's keep it absolute terms right now. Let's say that we want measures to be DALIs. Let's say that we want the metric to be rate. And the detail here, just in case you're wondering, the detail is related to how much detail we want for the countries with subnational units. So let's say that if we go to 3, for countries where we have subnational units, actually like it's broken down that like those estimates for each of the like subnational units. But let's keep it as level 1 just for simplicity today. And let's see what's showing on. Like the best way to make sure that you are seeing what you want to see is looking at the title map. So here we are looking at HIV/AIDS, and we are looking at the absolute difference between sexes calculated as females minus males for age standardized DALIs in 2023 and DALI rates in 2023. And one thing that we try to do, because we feel that like sometimes this interpretation of absolute terms or absolute differences and relative differences are not like very intuitive. So one thing that we have done was that we added, if you hover over a location, it will give you the correct interpretation. So we can see, for example, that in Congo, the absolute difference actually like disfavor females. And females have over 4,000 more DALIs per 100 population compared to males. One thing that we can easily see from the map here is the different colors, right? I don't know if you remember when I was going over the paper major results, I mentioned that at the global level, HIV was disfavoring females. And I also mentioned that was a unique situation, mostly coming from what's happening in sub-Saharan Africa. And this is very easy to see with this map. So we can see that all countries colored in green, that means that the rate of DALIs for HIV are higher among males, and all countries colored in purple, the purple shade, means that the rates are higher among females. And this is like very easy to compare to the presentation that I mentioned. So we can see that for most locations, actually the difference amongst males and females are small because they are closer to 0 and the like gray color over here. But if we go to sub-Saharan Africa, we see that actually that has like a different pattern. We see that for most locations, the burden is still disfavor females, with some of the gaps being like very large, such as in Congo, Gabon, Angola, and Zambia. So this is like a way that you can use the tool to like see this diverging geographical patterns in sex differences for specific conditions. Another good example, I'm just gonna show you something that's different. Let's go to mental disorders. So let's go to a level 3. Let's go to anxiety. Okay, so this is like a very interesting results where we actually see no geographical difference in the direction of the sex difference. We see that like across the globe, females, because we are seeing that the map is mostly colored in purple. So for most locations, the burden of anxiety disorders, they actually disfavor females. And you can also realize that the shade of the purple is very intense in some locations, meaning that the absolute gap between males and females is way larger in those locations compared to others. And we can see here, for example, in Brazil, the rate of DALYs for anxiety disorders in 2023 is over like 700. Like we have 700 more DALYs per 100,000 among females compared to males. Where in some other locations, we can go here in Algeria, for example, that gap is not that wild, but it still disfavors females. So this is like one way of like exploring geographical differences and the intensity or the magnitude of the gap using like the maps. It's very intuitive and it's a very easy thing to do. If you want to see how things changed over time, although this is not the best usage of like maps, I would say, if you're interested in a specific year, let's go, for example, you can toggle here the year. Let's go to 2002, for example. We can like see how things changed or whether they have changed over time. So I'm gonna go and move ahead to like a second visual. I'm gonna skip the ranking for now, but let's go to the heat map. So the heat map is very interesting because like for the map, you basically need to select either a cause or a risk and use that comparison, like compare across locations for one specific cause of burden or cause of death. But here with the heat map, we are actually able to do both things. We are actually able to compare across the sex difference across a range of outcomes or health outcomes across also a range of locations. So it comes, the visualization here, the plot comes pre-populated, let's say, with a list of countries, and those countries are we try to be as representative as possible. So we basically selected the most populous countries across the different super regions. So we have at least like one country in like one or two countries in Latin America. We have countries in Southeast Asia. We have like high income locations as well. And on the y-axis here, we see a list of like health outcomes, and it comes pre-populated with the level 2 GBD causes. So here we are still seeing DALYs. We are still seeing we are seeing the list of like level 2 causes. I'm gonna move the year back to 2023. Yep. And we are still like looking at the absolute difference between females and males. We are still looking at age standardized and its DALY in rates. So this is like a very interesting way that like you can see both the magnitude of the differences across the conditions, but also any diverging patterns across geographical units. So let's look at like neoplasms, for example, which I think is a very interesting group of causes. We can see that for most of the countries that were here like pre-selected, neoplasms were in general disfavoring males. But in locations such as like the DRC, Congo, Ethiopia, Bangladesh, Nigeria, Pakistan, actually the burden of neoplasms is higher among females compared to males. And this is like true for other causes as well. So we can see that, like, for example, here we have chronic respiratory conditions, while for most of the other locations, it disfavors males. In Bangladesh and Pakistan, actually the burden of chronic respiratory conditions is higher among females. And you can play as much as you want here. Let's explore the chronic respiratory conditions a little bit more. So let's say that we want to look at, wait, let me go to level 3 here. Yeah. So let's say that I want to fully understand what's going on with chronic respiratory conditions. So I actually move to level 3 for causes, which is going to disaggregate those like chronic respiratory conditions into more detailed causes. So if we look at the burden of chronic respiratory, of the different burden chronic respiratory conditions across, let's say that let's change the locations as well. So if you want to change the countries on the top, you can just like come here, remove the ones that are pre-selected. You can go to a location group. Let's put South Asia. Oh, it's actually can select the countries that I'm interested in South Asia. So, okay. So we have here that there are like some interesting diverging patterns for us to look at. Let's look at specifically COPD. We see that like COPD might be the cause that's driving that diverging patterns across the larger or the broader group of chronic respiratory conditions in South Asia, because we have countries such as like India and this is the region, but like we have countries like India where the burden is way higher among males compared to females for COPD, while in other locations such as like Bangladesh, Pakistan, Nepal, and Bhutan, the burden of COPD is actually higher among females. And we can think about like how we can connect things and how we can think about like policy discussions and interventions if we actually go to and change to like the display to risk. So we can choose the same group of conditions that we were looking at before. Let me pick COPD. Here you go. And then like it's the same thing for level, we are gonna disaggregate the GBD risk factors. And this gives us like a good idea of like what's going on with COPD in South Asia and why we have those diverging patterns. Because here we are seeing like the burden attributable to risk, the burden of COPD attributable to risk factors, to level 3 risk factors in South Asia. So we can see that in Bangladesh, we have like a larger burden of COPD attributable to smoking among males. But if we think about like other risks of COPD, such as air pollution and secondhand smoke, actually the burden attributable to those risks specifically, or the contribution of those risks to the burden of COPD in those countries, they are actually disfavoring females. So that's why when we think about like the combination or the total burden of COPD, we have like some diverging patterns because there are like diverging exposure patterns to different risk factors across the different locations in South Asia. So this is just like a quick example of like how you can explore things and like also connect like causes with risks and seeing like the divergent patterns and trying to get some insights of like why we are seeing or what's contributing to the differences in the cause level if we explore like risk factors a little bit more in detail. I'll go to like the next plot now. And this plot is a little bit different because I have been telling you that the different thing about this plot or this visualization tool and the GBD Compare is that like this tool focuses on the actual calculated differences, either like a relative difference or absolute difference between males and females. But it would not make sense for us to make like a sex difference tool without providing a plot like this, where you actually show the level of burden among males and females separately in a way that like if people still wants to know about the level, but they want that like direct comparison, they're still able to get this from our tool. And I think like this one is a very interesting way of visualizing how things either like have changed over time. So you can see that there is a possibility of you to select year, but also how things have evolved in terms of age. So I think like one interesting example, let me go back to cause here. And let's do ischemic heart disease. And let's change our age group. Let's do 20 plus. 20 plus rate of the, let's look at the title again. So this is a global level, the burden in ischemic heart disease, in DALI rates, and let's see how it changed over age. Actually, let's stay here a little bit more. Yeah, so we can see that like this is like one of the major results that we also presented in our study. Remember that I mentioned that like one key finding was that for many of the conditions, we were actually seeing like a decrease in the burden for males and for females in general. But actually the gap or the difference between females and males were not changing over time. So we can see here that we barely have like had any change over time for ischemic heart disease. And that actually made the difference or the gap, the difference between those two plots, like basically remain stable over time. So this is like a way of like seeing that. Another one that's a little bit different is other musculoskeletal disorders. So I'll go to age for this one. Okay, this one is interesting because it actually shows how the difference or the gap between males and females behave like over age. So we can see here that actually we start with like barely like no difference between males and females, and then that gap starts to widen. If you hover over, you can find the actual level or the burden for males and females separate for each age group. So you can see that like around age 60 here is where the gap or the difference between males and females is the larger. And then after that, the gap between the two sexes starts to decrease. The other important thing, and this was like a key takeaway from our study as well, was that if you go to mental disorders, so another key takeaway that was picked up by the media, let me go to rate. Okay, yeah. Uh, that looks correct. So like the another point that was picked up by the media was about like when the differences in the burden of mental health disorders start to happening or affecting when that like sex difference starts. And we found that like it starts as early as, so our study started at 10. So even at like very young ages, we already see like a difference in the burden of like mental health disorders between like males and females. So even like young girls, they are already like facing a higher burden of mental health disorders compared to males. So I'll move to the to one of the last plots here. And for this one, I'm going to select another cause that we are already familiar with at this point. So let's go to HIV. And I'm going to remove this pre-selected locations. And I'll let's go to Sub-Saharan Africa. Okay, so this is like Sub-Saharan Africa results. So the different regions within Sub-Saharan Africa for the burden of HIV represented in, so this one is what it shows is not more like the different levels of females and males, but the actual calculated difference in absolute terms for the rate of DALYs of HIV in age standardized. And this is over time. So one thing that we can see, let's pick here. So this is Central Sub-Saharan Africa. We can see that the gap disfavoring females is started to increase up to when it reached its peak around the year 2002. But actually, what we are seeing with this map, with this plot, is that the actual gap is decreasing over time. So it's decreasing. So we are getting closer, like the rate among women is getting closer to the rate that we find among men. And this is, of course, like in absolute terms. So that means that it's it does not necessarily mean that the lines are converging, but it means that the absolute difference is shrinking. And that might be because we are like actually reducing the overall burden of HIV among males and females. And how do we confirm that? So we can actually change here to relative difference. So the relative difference, the interpretation is a little bit different. If you come here, it's going to tell you that, for example, the burden of HIV in 2006 in Central Sub-Saharan Africa. So the relative difference in rate was 89% higher DALYs per 100,000 among females compared to males. And we can see here that what I mentioned, it was like mostly true, especially in the recent years. So in the recent years, it basically shows us that the relative difference between males and females have not changed that much. But because we see that like steep decline over time, it means that the burden is actually at some point, we actually decrease, we converge those lines. But more recently, what has been happening is that like we are actually decreasing the burden among both males and females, but not changing the relative difference between the two sexes. So this is like a cool way of like seeing this is specifically this plot here is specifically important or useful if you're interested in how we are closing gaps or how much improvement we are making in closing the gaps between males and females for like a range of like conditions. So I'll go to I know that like I want to give us time for like some QA. So I'm gonna change now like a little bit. So we are going to move out from like the comparison of female and male like gaps to like go into like that plot that I mentioned during my presentation that I was like specifically interested in which is the different rankings among males and females. So let me just go here. So I'm gonna choose all causes. I'm gonna put level 3. Actually, let's do this for risks a little bit so we can change the scope of the presentation a little bit. So I'm gonna choose here, let's do 15 to 49. So this shows like the ranking, and this is like a very cool, if you have like used GBD Compare before, probably like this is, at least for me, like when I'm writing papers or thinking about like future research, the ranking is something that I use a lot. So, but now this is like very interesting because it allows me to compare directly males to females without having to actually shift between like different visuals. So one visual for male and one vision for female. So let's see what we are seeing over here. So basically, we are seeing for females on the left side and for males, for males, sorry, on the left side and for females on the right side, the ranking of level 3 risk factors at the global level in 2023 for the age 15 to 49. So it's the ranking of causes of DALYs measured in rates. So we can see here, so one thing that I mentioned during my presentation, for example, you can see that intimate partner violence and sexual violence against children are indeed the 4th and 5 leading risk factors for women of reproductive age globally. And that compares like the risks between the two sexes. So we can see that, let's see sexual violence against children. So it says that it's number 5 for women, but actually it goes down to number 11 for males. And if we keep the mouse here over the risk, it's going to give you both like the level of the burden. So how many DALYs per 100,000 is attributable to sexual violence against children, but also it will calculate and it will display to you the absolute difference in the rate and the relative difference in the rate for the burden of that risk, specifically for that specific population. The different lines here, they indicate, so the solid line indicates conditions or risks that are higher in the rank among women or present the same ranking between males and females, while the dashed lines indicate conditions such as like occupational injury, for example, which are like higher ranked among males compared to females. And the different colors here is similar to what we have in GBD Compare, which represents the different grouping of risk factors or the grouping of causes. In this case here, all the orange colored rows indicate like that those are metabolic risks, while the green ones indicate that those rows specific are environmental and occupational risks, and the purple ones, they represent behavioral risks. So this is like a very cool thing. I love this this view, and this was almost like a requirement from like GBD collaborators using GBD Compare and our tools. And I think like that really helps facilitating the sex differences analysis. So these were like the main visuals. I know that like we're running out of time, so I'm gonna stop share really quick because I do have just like one slide that I think it's important for me to go over. So this will be like super fast. It's loading. Wait, where's my, okay. So we already navigated the sex differences too. I'm gonna skip the key takeaways because I think like this one is the major point that I wanna make. So I hope at this point that it's clear that the GBD sex differences tool does not replace GBD Compare, but actually complements it. And we can like decide which tool to use based on our like main goals. So for example, if we are interested in looking at the levels of the burden for females, males, and both sexes separately, we should use GBD Compare. We should prioritize using GBD Compare. But if we are interested in looking at the gaps or the differences between females and males, the most useful tool would be the sex differences. Similarly, if we are interested in looking at sex-specific conditions, such as like cervical cancer, for example, where it doesn't allow us for like a sex difference or a sex comparison, like the GBD Compare is the best tool to use. While if we're interested in comparing the ranking of females against the ranking of males, like the sex differences as we just saw with that like last visual would be the one to use. So it's just like making easier for users to find the information they need for like future research or any of their intended uses. And as I mentioned, like we have a lot of like other GBD 2023 resources, such as like different trainings, even like a training on GBD Compare, and that you can have access to our like data and other visualizations too as well. And I'm gonna pass it over back to Sean.
Thank you, Luisa, for the great presentation. Um, we will now move to the Q&A segment. Before we do that, I just wanted to remind everyone that you can find a link or find a recording of this session posted on the link on the GBD Learning Center. And then also, I just wanted to plug, I'm posting a link to a survey about the webinars to help us improve future webinars on topics like these in the future. And we greatly appreciate your feedback. Um, Jumping into questions that have come in. One question is for conditions with historically underreported female morbidity, for example, chronic pain, autoimmune diseases, how does GBD address potential measurement bias in sex-specific estimates?
Yeah, that's a great question as well. Actually, because Uh, one of the things that like you probably noticed that I included like data biases as like one of the core areas of work of our gender quality metrics team. So one thing that we are trying to do right now, and we are in the process of doing, and I will have like a better answer for this question when we are done with this assessment, is that like we cannot think about like sex differences and the results that are being produced by the GBD without looking the underlying data or what's available. And what we are trying to do is for all causes and all risks across the GBD, we are actually going back to the underlying raw data that informs those estimates to check whether that data comes to us or is available in a sex disaggregated form, or if it only comes to us as an aggregated form or only representing one sex over the other. So this will be like very important for us because, for example, like we already know that like for Alzheimer's diseases, for example, which is like a condition that according to the GBD disproportionately affect females, most of the data used to generate those estimates are actually not sex disaggregated. So conditions that mostly affect older women, or not older women, but older people, efforts to collect that information or like scientific literature on that condition is actually not presenting or providing estimates of like prevalence, for example, in a sex disaggregated form. We know that like we have like during the estimation process of conditions, we have a process called like sex splitting, but that information is as good as the information available in the other sources that presents disaggregated information. And because we need to rely on those other sources to create like a sex ratio for a condition, we end up for some conditions losing some geographical variations or some age group variations that might exist. So this is something that we are paying like a close attention to. I know that like specific teams developing estimates for some of these conditions are also like improving their like sex splitting methods. But again, it all comes back to how much data we have to inform some of those decisions. we're going to have more about this, the data input assessment when we are ready with that part of the work.
Um, Thank you, Luisa. Another question that come in is what priority areas does GBD identify for reducing persistent sex disparities, especially in chronic diseases and injuries?
Yeah, so like I think like one of the key areas of investigation that we want to explore further is combining the information about like women's health and the information that we found related to sex differences, because like for a long time women's health have been understood as reproductive or maternal health. That means that the population group that was under the lights, let's say, is the reproductive age women. So one thing that like is a priority for us right now is to think a little bit more about like what's going on for like older aged women. And again, like I'm talking about women because this is like a major focus of our team. So we are trying to like give a little bit more attention to conditions such as like musculoskeletal disorders, uh, which are like conditions that not always are like given the attention they need, because one, they don't cause mortality, but they cause a lot of like uh, loss of like quality of life. So this is like a key priority of our team. The other thing I think would be going a little bit bigger, like deeper, into like the sex differences on the burden attributable to risk factors, and understanding a little bit more on that, because I think that's where we can intervene, right? Like if we think that like women or men are being exposed to different risks, we can, and we're not talking here about like alcohol or smoking necessarily, because those are like things that we know about, but we want to spend a little bit more time investigating some other risk factors and how that plays a role in the like end burden that we see, the sex differences in the burden that we see in the GBD estimates.
Thank you. Um, have you examined interactions between risk factors, specifically how the presence of two or more risk factors influences morbidity or life expectancy? Uh,
Yeah, we have not explored that, but this is like something that we have been discussing as well. So the co-occurrence of different risk factors and how that plays a role in like the burden in life expectancy. This is not something that we have done yet.
Another question here is Brazil shows one of the highest global male-female differences in DALYs due to anxiety disorders. What are the main drivers behind this gap, and how should we interpret it in terms of health policy prioritization?
Yeah, so like there are two things. So for the Brazil results for anxiety disorders, one, we have only looked at the absolute gap. So it might be that the actual burden, the level of the burden for anxiety disorders is very high in Brazil, meaning that like the resulting of that is the absolute gap being very large in the country, which I do think that is true. But we could have like confirmed that with like the relative difference, just to see, is it like that the burden is it's big for both sexes in the country, or is it that the specific relative gap is that high in the country? So we can think about a little bit about that. I think like one thing that we need to think about is like all the risk factors that also are related to anxiety disorders, thinking about like how to implement or how to think more about like mental health conditions or any conditions actually that don't cause premature mortality but are like drivers of disability, and how that plays a role and how we can like act from like primary healthcare systems or provide like support, especially like to women. I think like what the our results shed light on is how different countries and how different services need to tailor their like services and their like healthcare to the different needs of like males and females. It's very clear to us with that study that women and men will continue to show up in health services with like very different needs, And we need to take like sex and gender into consideration when either like screening for conditions or providing care or finding like ways to support those that population.
Um, how do these findings challenge or confirm the current state of knowledge related to health outcomes for sex differences?
Yeah, a lot of like the things like are already like known, right? Like we know that like women are like usually like live longer than men, not usually, but like in all countries, women have like a longer life expectancy compared to males. We know that like males face like a higher burden of like some of the risks and some of the conditions such as like growth injuries. So nothing of that is actually like super new. Uh, so this is like one point. I want to like we are not here saying that like oh this study was like super innovative in terms of like some of the findings, but it was the first time that we actually look at like GBD outputs with that intention of like this was like an intention of like comparatively assessing sex differences across like a range of conditions. While like in previous efforts, that discussion among sex differences was uh, restricted to cause specific or risk specific research. So this is one thing. The other thing that, but the other part that I do think that is unique that we have not been talking is how much some of the sex differences are persistent over time. So I think like that's something that we need to think about like we are making progress. Okay, we are making progress in decreasing the level of like some of the conditions, but we are not making any specific effort to decrease the sex differences that might be caused by like gender rooted aspects. So this is like one thing. The other thing that was like very interesting to us for was to think a little bit more about like the age aspect, thinking that like even like at a very young age, uh, little girls, for example, are already facing like a higher burden of mental disorder, and that like keeps consistent across the entire lifespan is something that was like very interesting to us.
And then one last question. Given the findings, what are the two most important unanswered questions that your research raises?
Yeah, I think like one of the things I already mentioned, I think like what's still unanswered, at least for us, is uh, so like what's going on with like older ages and what's going on with the underlying data that like are used as inputs to those estimates. So how much of the differences that we see are due to actual sex differences or they are due to any like modeling step that we take as part of the GBD. So this is like one part that we are hopefully taking care of, and we are going to have some answers and insights soon. This is like one thing. I think like the other thing is thinking a little bit more about the burden of risk factors and not only what comes out from the GBD, but so the differences in the burden attributed to risk factors that we see in the GBD right now, they are mostly due to one, exposure to risk factors, but also the different levels of occurrence of the outcomes that are linked to risk factors. But we have not comprehensively, systematically explore the relative risks and the difference in relative risks between males and females for some of the associations. So this is like not something that comes into play when we see the difference in sex for the burden attributed to risk factors. So this is like another thing that we keep like revisiting and thinking whether we should start like creating or assessing whether there is actual differences due to biological reasons, for example, in the relationship between some of the exposures and some of the outcomes. So this is something that we are also still exploring.
Thank you, Luisa. So that comes to the end of the Q&A segment and just some final, just closing here. Again, we'd like to really thank everyone for joining us today and the real active participation in the session. The GBD would not be possible without the Collaborator Network. The work that we do together really goes a long way in clarifying the nature of the health challenges we face as a global community. And our discussions assist with identifying possible solutions to those variety of challenges. We will continue to share recordings of webinars on the collaborator portal as well as the IHME website. Those are updated every week, so please look out for those in the future um, in case you missed any session or like to revisit them. Please do not hesitate to reach out if you have any additional questions. And thank you once again for being here. We really look forward to having you with us for other future sessions. And on behalf of IHME, we wish everyone a great rest of your day. And thank you very much. And yeah, hope everyone
Thank
has
you
a
so much,
great day.
everyone.
Thank you, everybody.
Thank you.
Bye.